I hope you will enjoy this webinar, which was made possible by Medtronic. I would like to start by asking Michele to tell us about the tragedy that struck Lombardia early March 2 months ago.
Yes, thank you very much, Robert. First of all, let me thank Medtronic for this kind invitation. And as you said, we are friends since a long time, so it's really a pleasure to be with you and to share with you some considerations about what's going on and what has been happening all over Europe. You said very interestingly, what is really true. I mean, we in Italy, and particularly in the region where I'm working, which is Lombardia, my hospital, San Raffaele Hospital, is located in Milano. And Milan, of course, is in this huge Italian region, which is Lombardia, where about 10 million people live. And we had to face this emergency, this outbreak, I would say suddenly, in a way which was not expected at all, in terms also of, let's say, aggressiveness of the diffusion of the disease. So on one side, we were the first region, not even nation, because actually, while in the center, in the south of Italy, this was not happening, in Lombardia and the regions close by, this was happening in a very, let's say, aggressive fashion and completely unexpected. So what we had to do, probably if I can have the first slide, I can, I can try to show you very briefly what is currently the situation in Italy. This has been updated to very few days ago. And you see that overall there have been the first curve you see going up more and more. It's the total number of cases which are now well higher than 200,000 cases. Then the second curve, which has reached a plateau, are the current cases, which are about 100,000. And then the third curve, which is the green or blue one, it's around 80,000 are patients recovered. And then, unfortunately, the red line, which is indicating the death patients, is around 30,000 cases. In the next slide, you see that the situation was involving, of course, all the Italian regions, but the biggest, largest number by far are those regarding the regions located in the northern part of Italy. You see at the beginning the steep curve, which fortunately has now, in terms of current cases, reached a plateau. And next slide. And this is the most encouraging one, because you see on one side the blue bars indicating the total number of cases, but you see the white curve, which is showing the new cases, which is fortunately going progressively down and down more and more. Next slide. Now, we just actually had this paper you see here, European Journal of Cardiothoracic Surgery impress accepted on the European Journal of Cardiothoracic Surgery. And the reason why I'm showing it to you is because in this paper we try to describe what was the attempt to quickly reorganize the cardiac surgery system and activity in our region to deal with the COVID-19 pandemic, specifically in this region, which was the most involved one in Italy, which is Lombardia. And actually, next slide, we had to quickly try to agree about important things. First of all, we received from the regional government the indication that the vast majority of the cardiac surgery centers in Italy had to be stopped in terms of elective cases. So in this region, there are about 20 cardiac surgery centers, and the vast majority of them, 16, did stop the elective activity. Then 4 hub centers were identified, and and all the others became spoke centers. So the 4 hub cardiovascular surgery centers were, of course, allowed to perform emergency cases, urgency cases, and also to consider for surgery cases which were defined as not deferrable beyond 2 months. So not really emergent cases, not really urgent, but for whom surgery should be considered within, let's say, 2 months. And all the spoke centers were called to refer to those 4 hub centers. Now you see here in this portion of the table, which is actually going to be printed in the accepted manuscript, that very quickly, in few hours, I would say, we had to decide who we were going to consider emergent, urgent cases or not deferrable. So, of course, guidelines are very important, but you see here from the cutoff and the numbers that we are not really following strictly the guidelines in terms of what we wrote down, but we try to focus on the attempt to provide care, to keep providing care, really to patients who were needing it in terms of on an emergent or urgent basis. So, for instance, you see that for acute aortic syndrome, we decided to identify patients for emergent surgery, of course, with acute aortic dissection, excluding those old with stroke or evident visceral malperfusion. We said we cannot really make waiting for surgery patients who have got an ascending aortic aneurysm larger than 6 centimeters, or those with a diameter more than 5.5 if there's been an important progression, or if the patient is a Marfan patient, or, which is rather uncommon, if he has got uncontrolled hypertension. For the aortic valve, we just fixed our attention on severe aortic stenosis with symptoms. So basically patients who were considered not deferrable. So, not on an emergent or urgent basis, but you cannot really say to those patients, we will operate on you next year. So we try to, of course, to provide surgery to this subset of patients. And then for aortic regurgitation, those with unstable condition in terms of hemodynamics or pulmonary edema. Next slide. Of course, for the mitral valve, mitral regurgitation is very rare, as we know, an emergent situation. So we just reported acute mitral insufficiency due to papillary muscle rupture or chordal rupture leading to pulmonary edema. And for severe mitral stenosis, just patients with pulmonary edema or hemodynamic instability. Of course, in terms of ischemic, let's say, coronary artery disease, unstable angina, severe left main, and subocclusive proximal LAD, or VSD or cardiac rupture. Next, and I believe it's also the last slide. For the endocarditis, I think the best thing to do is to follow, we decided that it was to follow the emergent or urgent classification according to the guidelines. And for biological or mechanical valve prosthesis, emergent or urgent cases in presence of heart failure, hemodynamic instability. Then, of course, you cannot forget about cardiac tamponade, atrial myxoma. We had a couple of those patients with really impressive, huge myxoma with valve obstruction, mitral valve obstruction, and emboli in other patient. And finally, we didn't want to stop the LVAD program because, and indeed it happened, you can have patients in cardiogenic shock supported with short-term devices who are not recovering, and you cannot really defer those patients. Either you put a long-term LVAD, or those patients are not going to survive. So this, I wanted to show you this table because it was really written, on a piece of paper on a desk all together with and proposed to the 4 hub centers to try to deal with the pandemic as soon as possible. So it's not really, let's say, deep in terms of science, but was a practical way to say, okay, let's first of all fix on these targets, and then we will see. And I will just say that interestingly, we did not have, as we thought, so many emergencies or urgencies. I asked my coworker to provide me the number, and from the 10th of March up to yesterday, actually we had just 63 cases on an emergent, urgent basis, and very few considered not deferrable. And we can probably discuss afterwards why this is happening, and we were waiting many more emergency and urgency cases than we had to deal with, actually.
Okay. Well, thank you, Michele. For those people who had a sound problem or connected somewhat later, you're here at a Medtronic webinar where we discuss the consequences of the coronavirus outbreak in Europe and the consequences on our profession. Now, my name is Robert Clouds. I work in Leiden and Amsterdam. Michele de Bonis is a surgeon from Milan, and Thomas Modine, a surgeon from Lille. We all had different experiences. You just heard how it affected Milan and devastated that area. And I would like now to ask Thomas, can you give us a picture on what happened in Lille in north of France during the early weeks of the outbreak?
Thank you, Robert. I think the situation in Lille has been following a bit what Michele has been describing very, very clearly. And to be honest, we have been all watching what was happening in Italy because they were in front of us in terms of dealing with the disease, and we were trying to learn a lot from what was happening there. So we have to acknowledge the Italian experience for this. So I mean, what I would say is after the first patient northeast of France, in the region of Mulhouse and Strasbourg. And immediately what has happened is that the local authorities here decided to evacuate the hospital in order to free the maximum of ITU beds, because we wanted to avoid what our Italian colleagues suffered from, is the availabilities of beds. So we had some time to cancel many cases in many specialties. We transformed, for example, a lung hospital into COVID hospital, and we canceled all non-urgent surgeries in terms of orthopedic, digestive surgery, urology, just to free as much ITU. When it comes to cardiac disease patients, the situation is very different. And I can tell you, in this situation, we have to add now to the cardiac disease risk factors, the COVID situation, because the problem we had here is that from one day to another, we have been trying to bring patients to the hospitals to be operated on, and these patients were exactly what Michele has been saying. So that means we made a small shift in the indication towards what we have considered to be at high risk. That Michele showed clearly in the tables that, for example, Marfan patients had to have a bigger diameter, bicuspid patients the same, aortic stenosis patients have to have at least a decreased ejection fraction, have suffered from pulmonary edema, have symptoms in order to be admitted in the hospital. And despite this, in the first days, because of the fear of COVID, patients were not showing. We didn't see them. And also, I think the other hospitals surrounding our university hospital, which was dedicated to COVID, were so focused on COVID, they forget to deal with the heart disease or cardiac disease patients. And for example, I give you one of the cases that shocked me. I was following a patient for an ascending aorta aneurysm. I was supposed to operate on her in March, and she had an ascending aorta dilated to 5 centimeters with a bicuspid valve. And the patient was calling the emergency center, suffering from chest pain, and they considered that it's not an immediate emergency. And she came to the hospital, and because of aortic dissection, 20 hours to admit her. So this is the problem, is beyond what internally we have been trying to do to offer the best and the most secure approach for our patients. There are some other issues which were happening around. So based on this, and we are the region which is touched by the third biggest number of COVID patients. It had a dramatic impact, not only on our practice, which we can discuss this later on, Robert, but also on the results and the outcomes of the patients in the hospital, but also after the admission.
Well, thank you, Thomas, for this introduction of what happened in Lille. I will try to shortly explain what happened in the Netherlands and focus on the problem of ICU beds. Can I have my slides, please? Next, please. So to give you a short idea of what happened in our country, we have a small country, but there are still 16 million people living there, with 16 cardiac centers, very organized in 8 university hospitals and 8 major teaching hospitals. We do about 16,000 cardiac procedures and each center does about between 500 and 1,500 cases. Next to that, we have hospitals. And this is so at the end of February, the last week of February actually, I was skiing for a week with my family in Cortina d'Ampezzo in the north of Italy. And we heard about some cases of COVID-19 infection around the area just north of Milan. And we thought, well, this be a few cases and will not be a big issue. But when I returned home, it became a tremendous issue, because in no time, many patients came to hospitals and needed those ICU beds. And the next slide will show you our problem. This is the number of, it's in Dutch, but you will be able to follow that the number of ICU beds per 100,000 inhabitants. And the average in Europe is 11.5, which is about the number they have in France and Italy. But you see in the Netherlands, we only have 6.4 ICU beds. And in Germany, there are up to 27 ICU beds per 100,000 inhabitants. And that shows how vulnerable our system is. The reason for having lower ICU beds is that there are many reasons, but we have a very effective system, and many older patients are not admitted to ICUs. And we have a very restricted policy in that respect. But with this coronavirus outbreak, we had an enormous problem, because to be able to increase the number of ICU beds, we had to basically stop most of the care in the hospital. Not only to those beds were available somehow, but the nurses were not available. Can you go to the next slide? So these are the number of patients in the ICU. And normally we have about 1,000 ICU beds in our country in total, of which 500 to 700 are occupied. And then suddenly we needed in the peak 2,000 ICU beds, because about 1,500 were occupied by COVID-19 patients. And the problem was that where do we get all the nurses from to and doctors to take care of these patients? So most were anesthesiologists, ICU nurses, anesthesia nurses that were brought from the OR to the ICUs, and that had so much impact on the OR schedule that we basically could only do emergencies. Fortunately, you can see that in the lower red panel that the new admissions in the ICU, this is up to 2 days ago, is really low now. And so slowly we're getting more room for breathing in the intensive care. In order to keep our system working, we decided that the outbreak in the south of our country, where Carnival was an important reason where people were having parties at the end of February, and they had a huge outbreak there. What we decided to do is to spread all the COVID-19 patients over the entire country. So patients were transferred from the south to the north. The distance is not far, not as big as in France or in Italy, but still it was a 4 or 5 hour drive with an ambulance. But that by doing that way, we could keep up some basic care in all the hospitals. So instead of what happened in Italy, that some hospitals were not performing cardiac surgery anymore, all cardiac centers were able to do some cardiac surgery, and it was evenly spread over the country. There was even a command center that had the total number of ICU beds in all 80 hospitals, and were able to distribute all the patients evenly over the country. Can I have the next slide, please? And here you can see that the situation on the right now and the number of COVID-19 positive patients is in this map, and you can see that there are really areas where there were very high infection rates, and you have to realize that only probably half the patients were only tested because we had a shortage in test capacity. But it's really concentrated in the south and some parts in the middle of our country, but in the north, there was hardly any infection. So people are now trying to find out what the reason for this is, but it's very interesting to see these regional differences, as you've seen in France and in Italy, and probably all over Europe. Next slide. Yeah, so what we did, and you can't read it, but that's okay, this is in Dutch, but what we did is like Michele showed you, we made an urgency list, and in red is the acute care. Because this is in Dutch, and the next slide translated in English. Can you give me the next slide? Yeah, perfect. So this is in English, where we made a red column of acute care that needs to be operated within 24 hours. In orange, it's urgent or high urgent within a day, a few days to a week. In yellow, it's kind of necessary care. And in green, really elective. So in green is when we postpone that, probably that doesn't have a major effect on the outcome of these patients. And as you go from green to yellow to orange, the effect of postponing surgery is becoming more and more important. And we're trying to use this list to categorize our patients. And in the peak of the outbreak, we only operated on red and orange patients. And now we're slowly going into the yellow area as we're expanding the number of operations we can do. Currently, we're still at about 50% of our normal capacity. So it's far from ideal, but this gives sort of a handle of what we can do in our country. So how are you gonna deal, Michele, with the future selection of patients? Currently, you probably can do a little bit more. Are you gonna open up those centers that were closed? Or what's going to happen in the next few weeks?
Yes, well, the idea now, well, first of all, we don't know exactly why, as you said, even in Netherlands, in Italy, in France, and so on, we have a different distribution in terms of spreading of the disease. This is still something which remains very unclear. In Italy, what happened is that on the 4th of May, the lockdown has basically been not completely removed, but you know, it has become much more weak than it was. Currently, for instance, I'm not yet allowed to move out from my region. So this, of course, has also an impact on the care of the patients. We cannot go to make outpatient clinic outside of our region, but we will see now the effects of this decreasing strength of the lockdown starting 2 days ago. probably by the end of the month. So I believe that currently there is also a lot of, let's say, attention which is paid to understand where we are going. Meanwhile, as a matter of fact, we could observe two important points. The first one, as I said, is that we were waiting many more cases in terms of emergent and urgent cases than we had to deal with. And the explanation for that is that probably patients were so concerned about the possibility of getting infected coming to the hospital that they try not to come as much as possible. And the proof of this, as Thomas was saying, is that we have seen things we usually never see. I recall a patient who had been operated with he had aortic and mitral valve replacement, and he developed endocarditis, but he came to our attention when we could do absolutely nothing, because actually the two prostheses were completely detached and the patient was in a terminal shock. So on one side, we've seen less cases than we were expected, probably because patients tried as much as possible not to come to the hospital. On the other hand, those who arrived, I'm also thinking about acute myocardial infarction, arrived later than usually, sometimes too late. And we are starting to think about treating possibly now even not deferrable cases, which means patients who might wait for surgery a few weeks, possibly we use as a cut of 60 days, 2 months, but those patients probably from the mid of May, so maybe in 1 week, 10 days, we will start to admit them more, trying to go back to half of our, let's say, potential. We have usually we've been performing always 6 cases a day in my center. So far, we have been dealing with, as an average, probably 2 cases a day. We will try to go back to 3 to 4 cases probably next week or in 10 days and see what's happening. One important limitation is actually is represented by the availability of beds in the intensive care unit, because many of those beds actually are at the moment filled by patients who are not surgical candidates, but who were sent to the, let's say, cardiac surgery intensive care unit because all the other beds, intensive beds, up to a short time ago, were filled by COVID patients. Now this is getting better. So some of those COVID units, also intensive COVID units, are, let's say, starting to go back to their normal activity. So hopefully by the 3rd week of May, we should be able to perform around 60% of our normal activity, and we will see what's going to happen.
And are you going to open up those centers that were completely stopped doing cardiac surgery?
Well, this is something I personally think would be a good decision. I don't see at the moment the need to keep them closed currently, but this is not a decision which we can take on our own. It's a decision which is coming from the regional government. So I'm aware about the fact that this has been asked, and we are waiting in a few days the reply to that. It has been an interesting experience also in terms of, let's say, sharing the care with our colleagues, because of course it's very easy to understand that if you have a patient who is not emergent or urgent, you have been following for some time, this patient, even if he has been followed in a spoke center, wishes to be operated by the surgeon he was trusting. So this is something which has to be considered. So the way we try to deal with this is to welcome as much as possible colleagues, cardiac surgeons from the spoke centers to come to our unit and basically to do the operation in our unit with some of our staff in order to, to share the care of the patients, which was, I think, a very positive experience overall.
Thomas, can I ask you a question? I was called a few weeks ago by colleagues from Paris to ask whether we had additional ECMO equipment for their patients to treat. And I was very surprised because in our country, we have maybe a handful of patients put on ECMO, but it appeared that in Paris, and I don't know how it's in Lille, many patients were put on ECMO. So can you share us your experience with that therapy?
Yes, so ECMO patients, we put almost 30 patients under ECMO for COVID cases. And we started, I think, very early in the same time as our colleagues from Paris. And the idea was that we have been facing a lung disease at the end, much more than cardiac disease, although COVID patients do have myocardial inflammation. So we started doing ECMO in our patients in the beginning very late, and in the beginning on not necessarily patients with the best prognosis, but because we how do we say, we wanted to learn, actually, because in the beginning, the indication of ECMO itself was more or less random. And then we started feeling that it's working. Patients are not getting better, but they are stable in terms of control of the respiratory parameters. The problem is we immediately thought that we will be facing different challenges with the ECMO. The first one is the direct impact of the ECMO, because it necessitates human and technical resources. The human resources, that means you need the perfusionist, you need the nurses, which, as you know, if you have a patient under ECMO, he needs a full-time nurse to be dealing with. And he needs also, because he's a COVID, a dedicated anesthetist. So we were blocking for each patient under ECMO for COVID, a full team, which activities. And then once you have implanted the ECMO, you have the surgeon who has to be there. And also you need the perfusionist to be available to be sure that all the parameters are correct. And in a hospital like mine, where the cardiac surgery is one building and the ITU beds are sometimes 500 or 1 kilometer away, it could be a big issue. So that means once you have inserted an ECMO, you have implanted an ECMO in one patient, you can be sure that you don't have enough resources availability to keep on dealing with even the red patients of cardiac surgery that have been validated to be immediate or acute emergencies. So this is one of the problems we had with the ECMO. And then the prognosis. So as you know, I mean, the majority of patients, although the COVID touches a wide variety of ages and sex also, we have learned that the majority of patients were obese. Obesity was a big risk factor. So for ECMO, it's not always easy also. They were also diabetic. So the thing is, if you have 30 machines of ECMO, to whom you offer the machine? And we were not only facing for the ECMO indication, the human resources problem, but also the ethical problem. So this is what we were trying to deal with. So at the beginning, we wanted to keep the resources available, and we were implanted late. And then we started implanting very early. And I must say, for example, in our experience, out of almost 30 ECMO patients implanted with COVID syndrome, at least 1/3 recovered thanks to ECMO, I believe. And this is a good thing that we have learned from it. And so in addition to this red Robert, and which was recommended by the French Society of Cardiac Surgery, we have added also some other factors which are mandatory for a team like ours, is how to deal with the resources, because you needed to have people or surgeons, anesthetists, and nurses available 24 hours a day to be able to treat our cardiac surgery patients, which is the age, the comorbidities, and also the limited number of machines. So we added one more column, which is very important. So this is our experience with ECMO. And I think if ever it happened to face this kind of second wave or whatever, I think we will be using ECMO more and more. I think in Paris, they have implanted more than 200 ECMO patients.
But
it's a huge experience.
Thomas, do you believe, because, my center is has got an intensive care unit which is a really very active ECMO program, at least for Italy. They do use ECMO in more than between 100 and 120 patients per year for, cardiogenic shock and whatever. But the issue is, in these specific circumstances, the overall number of patients who underwent ECMO implantation in my hospital was less than 20, actually, which was a surprising somehow. So the question is whether, and this is, let's say, in line with what Robert is experiencing in Netherlands. Results are probably comparable, probably 1/3 of the patient or even less, let's say, survived, either because at the beginning the implantation was performed too late. But the issue is, where is the right policy? I mean, have been waiting too long before using it, particularly at the beginning. The number in France are explainable by the fact, particularly in the Paris area, that implantation was performed since the beginning, much earlier than in other centers. The reason why I'm asking is because, exactly as you said, if you have to run in 1 or 2 centers 200 ECMO in 40 days, this is really astonishing in terms of resources, machine, organization. It's really incredible. And actually, this was probably the only situation, I'm talking about, the, let's say, Paris area, with those characteristics all over Europe. Because in the rest of Europe, numbers are rather comparison. You have, between 15 and 30 cases per center. So, I'm not sure whether these big numbers in Paris were because of an early policy in terms of implantation, or just because of the logistic. So you have a lot of machine, a lot of resources. You are used with, to use ECMO very early, and therefore this translates into those incredibly high number. What is your opinion about that?
This is a very important question, Michele, and I think this points out the situation. Actually, we have a multitude of variables that everybody's trying to pick here and there and say this is the best way to do, or this is the worst way to do. And ECMO is one of them. I totally agree with you. And once you have picked the ECMO variable and to see if it's working or not, there are some other boxes that you have to. Logistics that, and how effective is the therapy? And I agree with you. If you don't consider at which stage you have put the machine, you will never be able to prove the efficacy or the non-efficacy of the treatment itself. And it comes like to the comparison of the efficacy of a chloroquine. If you do it early or not, and if the patient is capable of to recover alone, or if it is the ECMO effect. I think we have to be very humble with this situation, collect the maximum data that we could collect and make a comparison. We're not going to run randomized controlled trials, but it's very important. We may have this French paradox based on the ECMO thing, and I agree with you. In Paris, they have a huge number of machines. For example, you take the La Pitié-Salpêtrière, and you know that this team, for example, is a huge ECMO team. easier than a cardiac surgeon. So probably there was a tendency or a clinical indication because they believe that at some stage ECMO is working. Is it true in all patients? It should be generalized to everybody. I'm not sure. I agree with you. We have to look very calmly at the results and the data, compare patients who are comparable, and then come out with the probable guidelines that could be used in the future, not only in Paris, but also in Lombardy, in Amsterdam, and Lille. And this is a very important point, and not only about the ECMO, but ECMO is a very good specificity because it has a direct impact on what we're doing today, or what we'll be doing also tomorrow. Not only about the availabilities of the machines, but how do you run a unit of 200 ECMO machines, for example. I agree with you. This is very important.
Yeah, I agree, Thomas. There are many things we don't know, and as our Prime Minister said, we have to take 100% of the decisions with only 50% of the knowledge. So it's a very, very complex situation, and we have to see what happens. I want to go to another topic, that's the effects of postponing surgery for the patients that we were not able to treat. And Michele, what do you think are the major effects for the next few months on those patients? Will we see an increased mortality in those patients? And take that a little bit further in the future, please.
Yes. Well, first of all, I'm not sure whether you believe or not that we should be prepared about a kind of second phase or recurrence of this pandemia. I hope in a much less aggressive way. Let's say, maybe during the autumn time, after summer in October. I don't know when, but we will see if we really can go back to what we were doing before, which in my opinion is rather unlikely. Now, the implication of postponing surgery, first of all, depends on how good we are in trying really to select the cases in order to have the smallest impact according to the clinical situation of the patients. I was talking before about mitral regurgitation. We deal in our center with many patients who come to us from geographic areas which are far from our hospitals, particularly for degenerative mitral regurgitation and to have mitral repair. Now, those patients, in the vast majority of the cases, as we know, they are really rather stable patients. So for those patients, usually we perform early surgery in those patients. We do believe that if we make a mitral repair when there is no, atrial fibrillation, pulmonary hypertension symptoms, this is much better if the patient can have a good durable repair. So usually we do intervene quite early in this population. In this specific population, probably I don't think we will see major impacts in terms of consequences. Because if those patients are waiting surgery for, let's say, 1 year more, I'm not sure this will really have a major impact. If you're talking about a patient who is sick because of severe MR, normal left ventricular function, no atrial fibrillation, no pulmonary hypertension, no symptoms or few symptoms, but maybe just atrial dilatation. And this would represent in our center already an indication for early repair. In this population, probably we can ask them to wait without so much consequences. Completely different, of course, is the discussion if we are talking about aortic stenosis or in presence of LV dysfunction, advanced symptoms. And in this case, I think one of the effects we will see is possibly related to the fact that the patient will get surgery in his own region more frequently than it was happening in the past. In Italy, for instance, there is still a significant proportion of patients who move from one region to another according to the, let's say, specialty of the hospitals and cardiac surgery centers too. So a patient can come to Milano or Torino or Bologna from very far for a very specific, let's say, procedure. It is likely that until the situation is not completely solved, which I believe will just happen with the vaccine, I don't see vaccination, I don't see any really other complete solution to this problem. Meanwhile, I think that what we will see is a higher number of patients who will get their procedure, their surgery done close to their home, and so locally. That's one of the effects we will see. Then inevitably, there will be a proportion of patients who will pay the price of limited resources, limited number of cases we can perform. But again, it's very much depending on how we will be able to use proper criteria and try to minimize this. But we don't see it, we don't know exactly. We need to see month by month and try to adjust what we do according to the evolution of the situation.
Thank you, Michele. Thomas, when we discussed this issue last week, we talked about the loss of some of the specific patients group, the elderly patients. What do you think? Will the demography of our patient group, will that change? Have so many older patients being hit by this outbreak that we will see a change there? What are your ideas about this?
On the environment surrounding what's happening today and the psychological impact, my fear it will have necessarily an impact. And probably this impact will be diluted over time and it will disappear by going back to normal activity. It will take us some time to absorb the lack of cases operated, and because this is going to elongate a bit the waiting list in order to be absorbed completely. The thing I'm focused on today, and which makes me say that it's really difficult to pretend that this or that will happen here and there, except the political or the distribution of the patients itself, is the following: is that we have patients who are strictly in guidelines at the early stages. All the patients who are referred to us are either they have multivascular disease and severely touched at the level of the myocardium, or they have, because of the valvulopathy, also suffered at least from one heart failure, or have an low ejection fraction, or have atrial fibrillation. So they are not easy patients. And I think the number of non-easy patients that we're going to deal with in the future, just after the COVID, is going to increase. If you look at the patients we are treating today, they stay longer in the ITU. They are blocking the beds for a longer time. And we have been asked to do urgent patients, but also patients who are not here to block the ITU. But pragmatically, if you look at the facts, being chosen. And I think now we started, for example, looking on the waiting list and trying to define the patients who we will be starting to call to come to the hospital. And when we used to make the phone call, and all the patients were telling us they got weight, they have shortness of breath, they are not feeling good, or they experience at least 2 or 3 times chest pain. So they are not normal patients. So they're gonna have a direct impact on our immediate activity. And because of this, I think, again, ethically, we will have to be doing and making choices. Which patient we start by calling first? Is it the young patient because he has a better prognosis? And in that case, we are sacrificing the old ones. or the old ones because they are alone, they don't want. One of the most important and direct thing that you're going to deal with in our patients in the future, regardless their disease.
But
Yeah, I think many complex questions are going to be raised. And a last topic I want to discuss is whether what we experienced in our centers is that we lowered our threshold for interventions as the cath labs were still open and functioning, and they saw less acute patients, but they could deal with more coronary patients. And also, I'm not sure about that, but you could imagine that the threshold for TAVI was also lowered because that can be dealt in the cath lab without anesthesia, and we did not have enough OR capacity. Did you experience any shift in indication from surgery to intervention?
I think we did somehow this type of choice quite with a good level, let's say, of awareness, particularly in the initial phase when actually, despite trying to remain COVID-free, for instance, as cardiac surgery unit, this was not predictable because, for instance, we had a few cases where the patient was undergoing surgery and he was certainly COVID-free before the operation, after testing. Then after surgery, he became COVID positive, being in your unit, which was presumed to be a COVID-free. So particularly in that stage, when you were not really able to understand whether the spreading of the disease, even without inside the unit, was going to be controllable or not, we had cases where we lowered, let's say, the threshold, both for TAVI and also for PCI, I would say. The reason for that was also the higher safety for the patient. Because of course, if you do PCI and you do not do coronary artery bypass grafting, you are supposed to stay in the hospital much shorter. So also the risk for the patients in terms of getting infected was reasonably going to be lowered. This was not routine at all. So we did not change, let's say, common practice in a very significant way. But when the situation was, the typical, let's say, heart team discussion more towards surgery, in some of those patients, this time the decision was more towards the transcatheter approach. And it's very important, I believe, the question you asked before, Robert, in terms of the type of population we are going to face in the next future, because this can really be a scenario which somehow has been changed by the COVID. Because we should not forget that out of those 30,000 patients who died, for instance, in Italy, so far, unfortunately, the vast majority of them, they are old patients. Although, also there are a significant number of relatively young patients, but the vast majority remains represented by older patients. And those were the patients with the, larger number of comorbidities. Those were the patients who possibly we were presumed to treat with TAVI or a mitral clip or a TMVR, and not with a conventional surgical procedure. So probably we will see in the future a kind of shift in terms of candidates to these transcatheter approaches.
And Thomas?
Yeah, I mean, Robert, so far there is no single proof that cardiac surgery increases the risk of infection with the COVID.
Yeah, absolutely.
No one have shown this. So no one should use this excuse to make a shift outside the guidelines and the current evidence that we have, and more than ever. And Michele is right. I mean, we know that COVID patients are elderly patients, and also TAVI patients so far that are not easy to deal with are the elderly ones. But we know also that any patient who had aortic stenosis who is young, still so far the best treatment is aortic valve replacement. As far as you can provide him an operation in a safe place, COVID-free, with a dedicated team. I mean, we should not play with this. These are two different. Some temptation to use this and make a discussion, but not here.
I fully agree with you, Thomas, and I believe that this is something we should state even with more power now, when the situation is more somehow under control, and when we know more what we are dealing with or talking about. I was actually referring to the situation where, you know, we didn't really know what was going on and how there'd been the evolution of this. And so by definition, we have no evidence, of course, that cardiac surgery is increasing the risk of COVID. But the only rationale behind decreasing in few cases the threshold is in my unit currently, I have been having 3 patients who have become infected after the procedure. If the patient is needing postoperative care for 1 week, he will be exposed to this risk in my hospital for 1 week. If he can go home after 48 hours, this will inevitably, let's say, decrease the risk of exposure. But this is still related to few specific cases where you are in doubt whether, you know, surgery or PCI, surgery or TAVI is the best solution. And then probably decreasing the threshold in that specific context could have been considered acceptable. But I share with you the idea that this is not time to change indication, state of the art, and current evidence.
No, I fully agree. The issue I'm referring to is that I'm afraid for some considerable time we will confronted with a lack of capacity to operate patients, and then it doesn't become a matter whether one is better than the other, but if we just don't have the option to operate because our ORs are just limited in number, you might consider that some patients of having no treatment, they'll have an interventional treatment. That's something that could come.
Yeah, but this is an exception and not the rule. I agree, and it should stay like this. But you know, the most difficult thing was to bring the patient to the hospital, and once he's in the circuit, he's in the circuit. I mean, a nice aortic valve replacement, and you know how believer I am in TAVI and transcatheter therapy. So coming from my mouth, it has the importance that it has to has is that I mean, a good, quick, nice aortic valve replacement can make the patient be extubated very shortly after the operation, go back to the and leave the hospital, and you have been offering him the gold standard of treatments. And this is what we should do now. These times have learned that something very important in my mind is that doctors and the collaboration with the industry also is very important from this point of view, is we have much more responsibilities than before, and the example should be shown forever and more than ever. And I think this is one part of the game.
Well, I think that ends up with a very nice statement, Thomas. We have still a few questions left, and I was told that I'm allowed to let this webinar last for a few more minutes. So I would like to handle some of the questions that were placed to us. There was a question, a very practical point, that how we used protection measures that were taken in case of emergency operations. In our hospital, we used FP2 masks for the surgeons, and the anesthesiologists used more elaborate protection measurements. But that was basically all. So special masks and nothing else. But it was very, very rare to operate on these patients. I'm trying to find the next questions. There was a question about, or a remark about, that we need a more collaborative European healthcare system. I think that's something we all agree, but our politicians have to do it, and that's a big concern. A grow in urgent referrals during releasing lockdown phase. Well, in the Netherlands, we never had a complete lockdown. We had sort of we call it an intelligent lockdown, but that's obviously a Dutch remark. But people were a little bit more liberal to walk outside and go on the streets. I think the decrease in emergency cases in the beginning was indeed there was people were afraid to come to the hospital. That's for sure. But also there may be a biological reason that there's much less pollution. There were maybe less stress because people worked at home. So there may also be a biological reason, and that may indeed, in the current release of the restrictions, cause an increase in acute phases. I haven't seen it yet, but I wouldn't be surprised if there will be. I have not personally not operated on COVID plus patients, but my colleagues have, with a tracheal resection. So that was very, very tricky, and they used FP2 mask. Do you have operated on patients that you knew were COVID-19 positive?
We had to operate on a few of them, and what we did was basically what you said. We used protection devices, basically FP2 mask as surgeons, but that's it. I mean, I think it's very important, the remark, in my view, in terms of trying to, if not merge, at least have a kind of European response to a situation like this. I mean, if we really want to be European in the best sense of this, best meaning of this word, you know, in Europe, we should not have completely different or responses to this type of situation, and even more important, we should try to share as much as possible knowledge, organization, settings, decision-making process, in order to have a common response to a pandemic like this. I personally see this tragedy as a great opportunity for Europe, as a great opportunity for, let's say, for a reflection in terms of how much Europe is really integrated, starting from trying to face a major health care problem as the one we are dealing, and we are going to deal probably in the next future, until the situation will not be completely solved.
Yeah, two comments on this, if you may allow me. One is very practical with regard the protection as doctors we may have had treating with COVID patients. So we had very few COVID plus patients in whom we operated, except the ECMOs, as I've said. And very recently, one of my colleagues transplanted a young lady who was COVID plus also. But to be honest, we didn't have any particular protection systems. I mean, in France, especially in Lille, we didn't have this cosmonaut dressings from the head to the toe. We didn't have this. We just had the usual suspect protections that we are using every day, except the FFP2 masks. And it was very late to get, believe me, the first ECMO patients, they have been implanted just like doing any normal case, which is not good, I must admit, because we know that if you look in the environment of this disease, many doctors have been infected also, and many nurses, and this is not cool. And I can tell you, the first days I was really shaking and very, very stressed because of what was happening. So I think we should protect ourselves much more. And the other one is political. I totally agree with Michele. What we have to keep in mind is the positive things that has happened. Germany, for example, admitted patients from Italy, from France, from Spain, and there were kind of solidarity between the nations. And I think it's very important. And in a crisis like this, you see that there's no visible enemy. Economy is shut and touched for everybody and everyone. I think the only solution is to collaborate much more together than before. It's very important statement for today and tomorrow.
Robert, may I ask you to the most well-organized, let's say, nation in Europe in terms of management of the crisis. What do you think will happen of the intensive care unit beds, which in every hospital, including mine, have been increased 3 or 4 times as compared to what was the logistic before the pandemic? I mean, hopefully we will get out from this situation, and then the number of intensive care units bed we have been having in our units will be 4 times or at least 3 times what we were used to. So should we, let's say, keep after this a higher number of ICU beds by default? Should we go back to what we were before? Should we keep a portion of them and to use them, for instance, to decrease waiting lists where those waiting lists are present and resources were not available before? Because the interesting point is that if you have waiting list, you need to operate more. To have more ICU beds, you know better than me how much it is difficult. Now with this crisis, in 30 days, we had 4 times the number of ICU beds we had before. What are we going to do, or the government, in your idea, is going to do with these increased resources after the pandemic, or how we should?
Yeah, it's a very good point, and still a huge question mark how we're gonna deal with this. I'm a little bit pessimistic about the rapid development of a vaccine. I think it's a very complex virus, and if I listen to my virology friends, it will not be that easy as many people will say. Maybe we will get a medication to prevent the patients from going from a simple pneumonia into an ICU care situation. And that may be an easier pathway to block the disease process in these patients. But I'm afraid we'll have to deal for a certain number of months, maybe even years, with an increased impact on our intensive care unit beds. And indeed, we already have plans to increase the number of beds in the hospital. Physically, that's not an issue. It's simply rebuilding a floor with machines. The problem is the nurses. So we will rethink about how nurses are taking care of these patients. Maybe we'll train general nurses with additional short track ICU training specifically for this disease. And I indeed believe that the number of ICU beds in Europe will increase for the next few years to a much higher level than we have now. And we hopefully can also benefit from that. So for 25 years, I'm working in cardiac surgery, and I've always had to postpone patients or defer patients due to a shortage in ICU beds. And as you said, suddenly in 1 week time, we doubled the number of beds. I've asked for 1 additional beds for many years, never got it. Suddenly we created 1,000 beds in our country. So it's sometimes a bit frustrating what's happening, but this will definitely change the way we think about medicine and how we treat patients in ICUs. And I even heard a suggestion, which is not so strange, to set up separate hospitals for COVID patients, because it's a very specific care. You could organize ICUs in those hospitals, and you decrease the enormous effect on how we deliver healthcare in our country. This one disease has overwhelmed everything. So maybe if we treat this in specialized centers, we can sort of protect the normal healthcare system. And maybe that's another option to deal with. But I fully agree with what you've said about the collaboration in Europe. We need to gather the data we have now. We need to understand the data on ECMO. And collaboration in Europe will be more and more important. And I think also we have to rethink how why we get our medications from countries which are so far away. or we get our masks from countries so far away. We don't have very little industry, healthcare industry here in Europe, and that's something that has to change.
Yeah,
we will learn. We will learn tremendous amount of the way people work together. The appreciation of healthcare workers and nurses is increasing and getting back to the level what it used to be and should be. And I think with those remarks, I want to sort of finalize the webinar. I'm not sure, is there any last word you want to say, Michele?
I just want to say something else after Michele.
I usually try to see the good in everything, if I can.
You could.
So I see some goodness also in this, again, tragedy which we had to face. And one good point is that suddenly this disease forced all of us to think back once again to the real meaning of our profession. I've seen, nurses and all kind of healthcare providers trying to give their best, absolutely their best, beyond, working hours and everything, just to help. They could feel how important was in that moment for them to give as much as possible. So I've seen in this pandemic really a kind of personal feeling and personal emotion, bringing me back to the truth of our beautiful profession. And this is a value, I believe. This is a value which is there to stay. This is a value among us, health providers, doctors, nurses, and so on. And this is a value also in the relationship and the trust between patients and general population, generally speaking, and doctors. This is a situation where everybody was able to realize and see that doctors did their best. They, in Italy, as in every country, many of those doctors and nurses, they lost their life to try to serve as much as possible. And this is a value and a message which is, extremely important, particularly in those days and in those years.
Well, thank you,
So,
Michele.
Just one word in addition to what Michele was saying is that I feel signs that healthcare or medical systems are unlikely to be the adjustment variable that the governments have been using to make some economies. And I think this will be supported also by the population itself, because they see the value of having a good healthcare system, beds available, and healthcare which is offered to the majority of the population who work for it, actually. But also I see a good sign in this, that there's a kind of look back and to the relationship we must have with the industry. I mean, it's not because this is a sponsored webinar, but we must admit that without the support of the industry to find solutions, to have more ECMOs, more systems, more resources, many lives would have not been able to save. And I think we must be all very proud of the job that we have been doing from our side, from their sides also. And we should, being proud of all this, we can capitalize and claim what is good for us, but also for the people that we take care of. So this is my statement.
Thank you. Thank you, Thomas. Thank you, Michele. Thank you all, ladies and gentlemen, for listening to this webinar. We enjoyed your participation here. And also on behalf of Medtronic, I want to thank you for spending this evening listening to our experiences. I hope you enjoyed it. And for now, I wish you a very good dinner and a very safe execution of your profession. Thank you very much.
Thank you very much.
Thank you, Robert and Michele. Thank you very much, guys.
Bye, Thomas.
Pleasure.
Bye, Robert.
Bye-bye. Bye.